First on the agenda, I'm really pleased to introduce Dr. Brian Mittman to kick off the event. He's a senior scientist in the Division of Health Services Research and Implementation Science at Kaiser Permanente, Southern California, in the Department of Research and Evaluation. He's a longstanding member of the implementation science community, interested today in opportunities to reinvigorate and redirect the field for enhanced impact and value. So with that, I will hand it off. Thank you.
All right, my thanks to Sherry and Wayne for the invitation, for Stuart for the support, and I believe it was J.D. Smith and Allison Hamilton who encouraged Sherry to reach out to me. So my thanks to the two of you as well. So I suppose I could start by saying, subversion of what she said. Louder. Let's see if I can get closer and louder. Is that any better? Okay, I will try to stay as close as possible. As I was saying, I can start by saying what she said, basically that, the first several slides that I'll use are a summary and my version of what Sherry said about the state of our field. I'd like to spend most of my time talking about a set of potential solutions and in what is, ultimately a long and growing list of things that I think we could and should be doing better to enhance our impact. So let me remind you all of something which I hope you all have memorized, and that is the definition that when we published the opening editorial in Implementation Science, we adapted from previous definitions. And I've highlighted the key point that is relevant for today, and that is that ultimately our goal is to generate knowledge and insights, evidence to do science with the ultimate goal of improving quality and outcomes. And that's the real question and the growing recognition that we're not quite achieving what we set out to do. And I'll say that for those of us who were around back in the 1980s when the volume of activity really accelerated, if I'd known at that point that 40 years later we'd be having the same conversation, I'm not sure that I would have chosen to stay in that field, but that's another issue. So, we've been interested and have recognized quality gaps for decades. There was work beginning even in the late 1800s, early 1900s. Personally, I would say that the late 70s into the mid 80s is when the focused attention really ramped up. So as far as I'm concerned, we've been at this in an intensive way for about 40 years. So that's the time frame. And as you know, there have been and continue to be different bodies of activity under a lot of different labels. For me, changing physician behavior, and changing provider behavior were really the start of what I did call the more intensive focus. That initial work that identified and began to think about solutions to close quality gaps, to change physician and ultimately provider behavior, and then improvement science, implementation science, included a series of publications with titles such as these, basically pointing out the implementation gaps and identifying the problem. I show this slide in part to, in some way to provide the evidence base for my own observations, because I've been at this for a while and have had an opportunity to watch the field evolve, going back to the late 80s and the early 1990s. So to me, the question is the glass half empty or half full? Are we fulfilling not only our science mission to get grants and publish articles and produce evidence and theories and tools, but are we having a significant impact on policy and practice and ultimately on society in a way that a vaccine researcher does? Once that vaccine is, the evaluation, the studies are done, FDA approves it, and it's disseminated. And I think the answer, as Sherry said, and as others have been writing, is not necessarily. So Jeremy Grimshaw, before he retired, had his opportunity to sort of step back and take a look at where we've been and where we've come. And his impressions are similar to what I've summarized here, and what I think most of us would sort of conclude if we were asked the question, what have you done for me lately? What has the field done? We have a very robust, very rich body of theories and methods and measures and empirical studies, grants, publications, all of those usual scientific activity contributions. We have a very robust and rich and quite useful, from a policy practice perspective, set of evidence and insights regarding implementation barriers and challenges. So we know what the problem is and we know what's causing it. It's the solution piece where we're not doing quite as well as we'd like. And one of the reasons is actually found within that set of insights about the barriers. We've learned that there is extreme heterogeneity that plagues us in this field. One size never fits all. What we do in one place is highly unlikely to be feasible, let alone effective in another place. We know that contexts and needs vary, both across place, across site, but also across time. And what may work for one problem in one setting like Kaiser in the year 2025 may not work in the year 2027. We know that as a consequence, we need multi-level, multi-component, multi-stakeholder bundles. And that's a heavy lift. It's not the same as designing an intervention, a vaccine, and evaluating it as a simple intervention with extreme homogeneity where it's the same for everyone, and with very robust effects that tend to be strong across most patients. Life is not so simple for us. It's when, again, we looked at our contributions to policy and practice that things don't look quite as good. We have a growing body, as I said, of evidence regarding specific implementation strategies. Those tend to have very limited effects. We can go back to the 1970s and point to a series of studies that used CME approaches or chart reminders or financial incentives, with the common result being we succeeded in changing physician knowledge, but not practice, because the practices are influenced by and constrained by a set of other factors that we weren't able to address. So understanding that the effects of individual implementation strategies don't necessarily lead to the ultimate distal outcomes that we want, and that instead we need bundles that are matched to the very long list of barriers is, again, one of our challenges. We have managed to succeed in improving care within specific sites, participating in projects in the VA, in Kaiser, and the kinds of studies that we all do. Rachel has written extensively on the sustainment problem and the fact that we don't necessarily devote nearly as much research as we should on sustaining successful implementation. I'm more focused on the scale up and spread issue, and have been for a number of years, where there is in fact even less research and unfortunately even less impact. And I'll come back to that in my final slides. Actually, one other comment as far as half empty, half full, and again, Sherry said this, for the most part, the scale up, spread, success, the degree of adoption of ART is relatively good. Again, you can look at it half full, half empty. PrEP and other kinds of behavioral interventions and prevention strategies are doing so well. And that's actually part of a theme and a common pattern. We know as physicians and patients, we like simple solutions. So a drug that's effective is much more likely to be used than a prevention strategy, which you won't see effects for a number of years. And certainly not a behavioral strategy, which is much more difficult to deploy. So I won't spend any time on the next 2 or 3 slides, other than to point out, as Sherry said, that the field is increasingly looking back, reflecting. I'm not sure if it's cutting in and out for you. It sounds like it is for me. Okay. But again, the point is that, there's growing recognition that we're not necessarily accomplishing what we set out to do, and that we need to work a little bit harder. Again, I won't go through these in detail, but encourage you to take a look. I actually started thinking about this almost 10 years ago, a presentation I gave to the Implementation Research Institute fellows and faculty, really trying to think about why is it that we haven't necessarily achieved our policy practice goals. And one of the many, many reasons, and this is addressed in the pre-mortem article, is the idea that somewhat ironically, we tend to do what we criticized our clinical research colleagues for doing, and that is publishing the results of our study, showing that in the 20 VA clinics that were in our study, we achieved significant improvement. And then we walk away and go on to the next problem with the assumption that we built it and they will come. There are a number of problems with that, but again, it's one of the contributions to our limited impact. So we shouldn't necessarily continue doing what we're doing. We need to rethink our approach. And again, my thought that we need to reinvigorate and redirect our field. So how do we do that? We sit down and do what we would do to try to identify and address quality and implementation gaps. We document the gaps. We try to identify the root causes. What is it about the nature of the problem or the approaches that we're taking that are contributing to our limited impact? And what can we do about it? What are the multi-component, multi-stakeholder, multi-level implementation bundles that would target us as the implementation science field to change our practices so that we as researchers do a better job of properly identifying and studying and addressing the implementation gaps that we set out to address. So one of the issues is the fact that these are wicked problems. The answer with a capital A just doesn't exist. There will rarely, if ever, be implementation bundles that are simple and robust enough that they will have consistent effects and benefits across multiple settings. Again, the concepts of multi-level, multi-component, multi-stakeholder, and highly adaptable and tailored approaches. Those are the kinds of concepts that we need to keep in mind without hoping that there's a simple solution out there and that if we just continue trying different implementation strategies, eventually we'll hit the jackpot. So the conceptual model that's driving a lot of my thinking in a set of articles we're referring to for now is the ABC framework. We'll come up with a better name before we publish. And you probably recognize this as a simplification of CFIR. But this is an attempt to identify the root causes, the contributors to limited impact, and to provide a basis for identifying a set of recommendations, things that we could be doing better as a field to achieve more and better implementation, meaning societal impact, implementation at scale, not just within the participating sites. And I'll start with the innovations bucket, but point out that the innovations that I'm referring to here include complex health interventions in general. So it's not just the implementation bundles that we need to do a better job of developing and disseminating, but also some of the behavioral programs, the innovative care models. So the framework is meant to apply to complex health interventions as a broad category. So let me start with the innovations. And, the question here is, are we trying to sell our policy practice leaders a bill of goods that, doesn't meet their needs? And, Renad and colleagues talked about that. And the answer is more often than not, or at least too often, yes. And there are a number of reasons for this. One of the annoyances on the list is the fact that sometimes NIH will cut our budgets and eliminate elements of a project such as the economic analysis, the cost analysis. We finish our work, we succeeded in improving care, we try to sell it to another site. Those site leaders congratulate us and express keen interest in achieving the same goals and ask us what it's going to cost. And the answer is we don't know. There are a number of other features of the way that we go about designing, conducting our work, developing and evaluating, disseminating our implementation bundles that limit their value and the ability of others to adopt them, to use them, that limit the likelihood that they will adopt them and use them. The not invented here problem is one of the many issues on the list here. The fact that as a researcher, I'm unlikely to be seen as a credible source if I'm trying to convince another practice leader outside of Kaiser Permanente to adopt something. This is one example of many where partnership is one of the key goals. And we know that stakeholder engagement is important. We often don't think about how important it is across the entire spectrum of activities, not just when we sit down to design and conduct a study, but for all of the follow-through till the end. So again, in the interest of time, I won't go through this list, but the bottom line is that the goods that we produce and sell are often not adopted and don't have impact because they're really not ready for prime time. They were designed and optimized by and for the systems participating in the study. There's no ability to tailor them and adapt them to other settings. The kinds of tools and implementation manuals and other items that we produce that the potential adopters need just aren't there because that's not something that we're rewarded for doing. The reporting guidelines for complex health interventions that talk about the need to describe the dose and so on are also incomplete. They don't go far enough in guiding us in producing and sharing all of the intervention tools and materials. So again, a long list of things that apply directly to us as researchers in a research community. The work that I'm doing in this area is to try to develop a list of these recommendations, which are out there in the published literature, but they've never been compiled. So sometime later this year, and I hope before the December D&I meeting, I'll have finished the survey where I attempt to compile these and get feedback, and I hope put them together as a checklist or a laundry list of things that we as researchers and research funders could be doing better in order to ensure that our output is more likely to have impact rather than to be published and sit on the shelf. So let's turn to context. That's relatively simple. And the question here is, if we face a situation where the regulatory barriers or the reimbursement barriers are just too great, what do we do about it? My answer in many cases is look to another problem. But another answer is don't ignore them and focus only on the things that you can control, because of the influences that we can control, contribute to 5 or 10% of the variance, and external context contributes to 60%. We're wasting our time unless we try to address it. This is yet another area where partnership becomes important, because there are groups out there in the world, other than the research community, that actually are responsible for policy, regulatory policy and reimbursement. They need to be part of the team. And they need to take on responsibility for addressing those factors. Because again, working within our own system with our own limited ability to influence factors, if we're only influencing a subset, is not going to get us where we need to be. Let me jump to the far right-hand side before finishing with the bottom box, and that is the receptor organizations, the public health agencies, the healthcare delivery systems like Kaiser, like VA, and others. We know there are issues here, and we also know that the learning health system field, as well as quality improvement and all the other acronyms that have been floating around over the last 40 years, are working on this. The bottom line is healthcare organizations, in particular, public health agencies as well, are not really set up to rapidly and efficiently vet and adopt and tailor and sustain and spread innovations. And when we go to them to try to ask them to create that capacity and that interest from scratch, it's too heavy a lift. So at the same time that we're working on category A, which is to make sure that what we're developing, trying to sell, is more useful, we need to work on category C to make sure that our customers are set up in a way that would allow them to benefit from what we're doing. So developing a framework that identifies the required infrastructure and capacity and skills of organizations, and thinking about the kinds of regulatory factors that will convince them to do a better job. Those are among the lists, the items on this list. Just one other comment, and that is the idea that our implementation projects, when we follow our frameworks, begin with a period of documenting implementation gaps, followed by a period of assessing barriers and facilitators and identifying root causes of those gaps, followed by some pilot work and formative evaluation to design and preliminarily evaluate our implementation bundles, followed by the small-scale efficacy study, followed by the larger effectiveness study, followed by the sustainment work and the scale up and spread. That's for one implementation gap. Think about the number of implementation gaps that we need to address. So bottom line is, we're not going to get there through a project-by-project bottom-up approach. Again, we need to think about redesigning healthcare systems so this can be done much more efficiently. So let me wrap up with what I view as one of the major challenges and the major opportunities for improvement, and one that I'm devoting a fair amount of time to. And that is the concept that implementation is a team sport, or it takes a village. And the idea, again, that the researchers and members of the research team have very limited influence over the full spectrum of barriers. It's particularly problematic when we think about the way that, again, to go back to my vaccine example, how does a vaccine achieve, sort of global dominance, to use that phrase? It works because the researchers will conduct the basic science, develop the vaccine. Oftentimes, the academics will finish the phase 1 studies, and then either they start up a for-profit company or they license or sell it to a pharmaceutical company that then picks up and runs with it, which includes not only the phase 2 and phase 3 studies, but also the FDA approval and, most importantly, the marketing. When I develop and publish the results of my latest, most innovative, most effective implementation bundle that significantly improved HPV vaccination rates within Kaiser Southern California, it sits there. I'm not trained, I'm not incentivized to provide that national technical assistance and to support the scale up and spread. So part of what we need to do in order to enhance our impact is think about the full spectrum of groups that have influence over, and more importantly, have some interest and motivation, the mission to improve care. And within each of these categories are some stellar examples. The American Heart Association's Get With the Guidelines program is highly effective in improving cardiovascular care, because its mission includes not only providing education and support to patients and lobbying for more research funding and the other things that patient groups do, but also ensuring that clinicians are aware of and follow best practices. So working with that group to give them our implementation bundles that ideally we co-developed and evaluated with them allows us to hand over that package and ask with it. The American College of Surgeons runs the National Surgical Quality Improvement Program. Again, the same idea. Professional societies have, as with the patient advocacy groups, a lot of different missions, which include providing education and support for their members, lobbying in Congress for better reimbursement, but also providing support for their members in achieving higher quality care and outcomes. So again, working closely with that kind of group, but more importantly, encouraging all the other patient advocacy groups and professional associations that their job does not end when they publish clinical practice guidelines and walk away and assume because they built them, they will come and the world will follow. They need to follow that with the implementation work, and they need to work with us in a way that includes the expectation and the plan for them to help to scale and spread their work. Industry represents another partner, and this is where I've been doing a fair amount of work over the last couple of years, trying to identify the groups within the pharma and life science industry that are engaged in implementation science. ViiV, of course, was one of the first, but the role is not merely to fund the work, but instead to, again, take on responsibility for scale up and spread. And in the case of the pharmacy industry, it's the medical affairs teams that have the mission to help support better care. Primarily, of course, focused on their products, but more generally as well. So identifying these groups, identifying overlapping responsibilities in areas of mission, and partnering with them is, again, at least part of the solution. But I just want to again point out that no one of these is the answer, and that we have to be working on this simultaneously. You know, we're not going to convince the health systems to set up infrastructure to more rapidly be prepared for and to look for our output if our output isn't meeting their needs. And we're not going to convince the third-party spread facilitators to be more proactive, again, if we're not meeting their needs. So somehow figuring out how we can work on all four of these categories simultaneously is, in my view, what we need to do over the next 1, 10, 20 years in order to enhance our impact. So let me stop there. I don't know if I left any time for questions, but again, thanks for the opportunity. Look forward to a discussion over the rest of the day.
We have time for like 1 or 2 questions if folks want to ask anything.
Thank you very much. That was a really great introductory talk for this meeting. My name is Judy Auerbach. I'm here at UCSF. This is kind of a Judy kind of question. Having been in this arena for decades, let's just say, one of the questions that I'm always curious about from those of you here who are implementation science experts and define yourselves that way, how is implementation science, as we're all doing it and understanding it, actually different and distinct from historical health systems research, health services research, and operations research? And do those fields have boluses of information that can and should be informing how we do what we do, or are they just being ignored?
You know, I don't think we're ignoring them. You know, in my view, most of those fields are somewhat broader than implementation, and we can view implementation as a subset of the HSR, the health systems research. But, you know, I think that we all, you know, work in the same circles, and that anything that one group has discovered is quickly, you know, known by the other group. So, you know, and that's an example of one of the unfortunate challenges that we face. There aren't good answers out there that we need to find. You know, occasionally someone will pop up and say, gee, you know, the commercial, you know, marketing folks know how to do this. Why don't we just learn from them? We're already working with them. A lot of their insights don't apply to what we do. We're not selling iPods or other devices. So in general, we do need to continue interacting. But the main point is simple answers aren't there. And, in my view, we have the answers. It's not a matter of knowledge. I think it's a matter of will and capacity. Again, we know what the barriers are. We know that we need to tailor. We know that we need to develop more robust packages. It's just difficult to do. Our funding agencies don't support it. Our grants aren't large enough, and we often don't have the skills.
Unless someone else has a burning question, I think in the interest of time, we'll go to the next panel. Okay, that was an amazing introduction. Thank you so much.